Thanks, Sherry, and hi, everybody. I appreciate you joining the call. And what I wanted to do over the next probably actually 40 minutes or so is cover, how we've used and how others might consider using interval training in patients with different chronic diseases. And in terms of outline, I understand that many of you probably have done interval training yourselves before. Many of us have, but a little bit of the history, some of the basic principles and terminology, and then I'd say 40% of the slides or 50% of the slides will be looking at different patients with different chronic diseases and patients with those diseases and how interval training might fit in. I'll be a little bit cardiac centric because much of my work involves patients with cardiovascular disease, but hopefully I will touch sufficiently upon other patient populations to hold your interest. And then there's 3 or 4 outstanding issues that I want us that are kind of open-ended that I think we have to think about. Just in terms of background then, this is the improvements in world records for both men and women in the marathon run since the, let's say, early 1900s. And in both cases, you can see that performance times have decreased about 30 to 40%, across both genders. And similarly, clearly that's an aerobic event. Another quasi-aerobic event, it's about, let's say 4 minutes long or so, is world records for men and women for the 1,500-meter run. And again, you can see good improvement for both of those. In this case, about 10 or 15% improvement. Timing here is a little truncated with females starting in the 1970s. Men go back to the 1910 era. But in either case, there's been improvement. And my take-home message from this is, if one assumes that there's been no, and I think it's correct to assume it, but there's been no major shift in the last 100 years in the human gene pool that can account for genetics accounting for, this 10 to 15 to 20% improvement depending upon the event, that can account for these improvements in event times. What you're left with is other factors besides changes in the gene pool that might contribute, and I would argue that coming up to the top of the list would be such things such as maybe nutrition, or potentially for our topic today, training techniques, and interval training rising up as being one of those training techniques that probably has contributed greatly to the improvement in event times. And in terms of history, for those of you that are runners, you've probably heard of fartlek training before, which was, adopted or developed in the 1930s, which in some ways is an interval technique, but it's really more of a informal technique where you actually play with one's speed during a training run, that it might, with really no pattern per se, and progress from higher to slower speeds during the event. And then it was in the 1940s and 50s that cardiologist Rendell and physical educator Gershler really started to develop interval training as a technique and gave it some scientific shape and methodology, and organized it such that it was much more formal rather than soft or less formal in its approach. And this led to the 1958 paper that they published, where many argued, including the athletes, but other coaches argued that the training technique was simply just too tough for the athletes. But as you can see here, they studied over. Think of a study now that we might do at our own centers, but they studied over 3,000 athletes using a 100 to 200 meter training approach over 3 weeks. And their work interval, and I'll go on to define these in a second, was heart rates of 180. And again, these are probably college-age students. And when they let heart rate come down to 120, for their recovery interval, then they were up again. And they reported a 20% increase in heart volume using techniques back then, which were probably much less quantifiable than we have now with respect to myocardial imaging. But they reported good findings, and they themselves cited that some of the promises for HIT were it required less time. It clearly provided a greater stimulus, especially on the working muscles, and it was a more exact way, a more precise way, a more quantifiable way to go ahead and account for the work. And again, my apologies if many of you are familiar with this background material, but common terms would be what is popularized now is HIT or AIT, aerobic interval training. Both are the same. And as you can see by the little insertion of the figure there, it alternates work intervals and relief intervals over the course of a training bout, preceded by some warm-up and cool-down. The work intervals, at least clinically now, this might be different than your athletes, but at least clinically, you're usually training the patient up to 90–95% of heart rate reserve. And if you put that on an RPE scale, if you used a 1 to 10 scale, it's about a 7 to 9. If you use the 6 to 20 scale, it's about a 14, 15, or 16 in terms of the work interval. And then you have two types of relief intervals. One would be rest relief, where the athlete literally could be doing no exercise or moving very slowly, usually at around 50 to 60% of heart rate reserve. The patient would be moving very slowly at around 50 to 60% of heart rate reserve, or 4 to 5, or 8 to 10 on the respective RPE scales. Or you could have a work relief interval, which is we tend to use more in the clinical setting. We drop patients down to 60, 55 to 60%, up to maybe even 70% of heart rate reserve, and the RPEs are as shown there. So these are alternating work relief for intervals where you're stimulating the system, backing off, stimulating the system, and backing off. In addition, and again, these are probably not new terms, but in addition to HIT, we often use MIT with our patients. And this, again, it's the same type of thing where you're sequentially alternating work and relief intervals, but the work interval might only go up to 85%, which really is the upper end of ACSM and AACVPR and AHA recommendations for the traditional work intervals, maybe 80–85% of heart rate reserve. And the relief intervals now might be 60 to 70%, 55 to 70%. Moderate continuous training is what most of our patients probably do. They come in, they warm up, they go at one pace for their aerobic phase, they keep it at that pace or adjust very little, for their 20 minutes and get on a different modality and adjust. But usually it's a single pace, at a heart rate that falls between 60 to 80, maybe 85% of heart rate reserve. And then in some of our more deconditioned patients, I think of patients that might have heart failure, class 3B heart failure. We're looking at a training intensity that we've often referred to as LIT, low intensity. I've got that spelled wrong there, but low intensity interval training, LIIT. And your up intervals or your work intervals might be all of 70%, and your relief intervals might be 55 or 60% of heart rate reserve. So those are common terms that you'll see coming through. And not to bore us too much, but just so that we review, as we all recall from our exercise physiology classes as undergraduates, there are two primary tenets when we prescribe exercise. One is specificity of training. And clearly, if we want to develop great runners, they have to run, or great swimmers have to swim. Yes, there's a thing called cross-training, but at the elite level, that does not apply. For our patients, it might apply if they go from a recumbent bike to a treadmill to a stationary cycle. That's kind of cross-training, but given their fitness levels, they should adapt using HIT, MIT, or MCT. They should adapt well, because it is a aerobic activity that trains the skeletal muscles. And as we all recall, that if we were in a room and Yuri stood up and screamed out fire, for us to run out of the room because of the fire we would really, that's the green line there where I'm plotting energy system and exercise duration. We deplete our phosphocreatine stores, ATP stores, fairly quickly. And if we continue to want to exercise, we've got to bring on the aerobic pathways, which is shown in red here, or at least other pathways, which shown in red here is more anaerobic metabolism, which if it's purely running anaerobically, we can only do for a minute or 2 or 3, and then eventually that will start to tucker out and fail. And if we want to truly produce energy over 5, 6, 7, 8, 10 minutes, and we have to slow our pace down. So with respect to our patients and what we're asking them to do for 10, 15, 20, 25, 30 minutes, they're really stressing the aerobic pathway, which is the Krebs cycle and beta oxidation and oxidative phosphorylation, and those are running 90% aerobic metabolism because they're running for greater than 5, 6, 7, 8, 9, 10 minutes. But the second tenet though is to produce this adaptation. Now that we've got them training specifically for aerobic improvement, how do we load them up, so to speak? And as we're all aware, we produce the overload by changing intensity, duration, and frequency. And for our purposes here today, frequency is going to be probably still 3 or 4 times per week of aerobic training, or 5 times per week, although they may only do HIIT training once a week or maybe twice a week, and the duration of a training bout might still be 20 minutes or 30 minutes, but within that we're going to play with intensity and we're going to interval their intensity. So intensity is really what we're kind of focusing on today, by alternating their work and relief intensities during that training bout. Hopefully you've seen this. Hopefully you've seen this. Hold on for 1 second. A little bit of a situation here, but hopefully you've seen this figure before. And on the left axis, the y-axis, we're plotting improvement on the y-axis. We're plotting improvement on the x-axis. We're plotting whether it's intensity, duration, or frequency. And in general, you can see that if we don't do much intense work, or we don't exercise very frequently, or the duration is short-term, improvement is relatively mild. And on the extremes, if we do an awful lot or very intense, then we get a high degree of improvement, but it's somewhat diminishing returns. So we're really shooting for that midpoint of the training dose, so to speak, of 3, 4 times per week, 5 times per week, or a duration of 30 to 60 minutes, where we're going to get marked improvement in our outcomes. So just in terms of a HIIT training, if we're trying to train the aerobic system, at least clinically, what we kind of use at Henry Ford Hospital, and I do understand that other centers use a little bit different work to relief ratios. We tend to use a 1-to-1 or a 1.3-to-1 training bout, which is 4 minutes of an interval of work and 3 minutes of an interval of recovery. And we tend to use a work recovery, which would be mild exercise, whether it's walking or slow walking on the treadmill or slow biking. Again, at around probably 60-70% of heart rate reserve, and it's in that middle column there, bottom row, which is what we're focusing then on today in terms of a training model. As I showed you before, it's alternating work and relief intervals, and you can see here that this is actually data from a specific patient, and we've just inserted now the training ranges to show you that after warm-up, they have 4 bouts of work and several bouts of relief. And the work bouts were up to 90% of heart rate reserve, and the relief intervals or recovery intervals were about 70% of heart rate reserve, and then they go into cool down. Same thing here, but instead of using percentages, we're just using absolute numbers. This patient's training range was 130 to 139, and their recovery intervals were 114 to 124. So same model, but using heart rates rather than percentages. This slide now starts to show a summary of the different studies that have been looking at HIT in patients with cardiovascular disease, those with coronary disease, those with heart failure, a couple of patients with transplant, one study looking at MI, and all the way back to 2004 or so. And in each case, you can see, I'm going way over to results. In each case, you can say there's usually a 2 or 3-fold % improvement, and all of these usually compared to moderate continuous training, a 2 to 3-fold improvement in aerobic capacity as measured by peak VO2. Some studies looked at flow-mediated dilatation and showed improvement as well. But then if you look at the middle column, you can see many of them also used a 4x4. We use a 4x3 or a 4x4 training intensity with about 80 to 90% of VO2 peak or heart rate reserve. So these seem to be somewhat similar across the board, and in general resulted in greater physiologic improvements. One thing I did want to mention, not all of our patients are able to tolerate HIT, so we do use MIT, moderate intensity interval training, and this is the same kind of slide I showed you before, but the upper work interval now is just towards the upper end of a normally prescribed training range that might be 60 to 80%. We're pushing people up to the upper end of their training range, backing them down, pushing them up again for 4 minutes or so, and then backing them down using MIT. So I showed you several slides now that have talked about intensity of training, and one even showed about change in VO2. This was a recent paper that was published, and it was a summary paper that looked at intensity level and response to interval training, response of peak VO2, and they looked across the intensity of different types of training. And as you can clearly see here, that as we progress from relatively very low intensities, 20 to 40%, and then got into moderate, somewhat vigorous, 40 to 60%, 40 to 80%. And then when we really pushed it up, 85% of heart rate reserve, the percent improvement in peak VO2, a little bit of an exponential or dramatic increase compared to the more moderate training levels, moderate vigorous training levels. Here's a classic study by Wisløff, Ulrik Wisløff out of Norway, Trondheim, where really caught everybody's attention when it was applied to patients with heart failure. Randomized 27 patients to either interval training, AIT here, aerobic interval training, moderate continuous training, or control. And you can see that both oxygen uptake, peak oxygen uptake, and endothelial function as measured by flow-mediated dilatation improved in both the moderate continuous training group compared to control and the aerobic interval training group compared to control. And when you compared aerobic interval training compared to moderate continuous training, the middle two figures, you can see a bigger effect with training at 90% of heart rate reserve. Wisløff's group has really done an awful lot of work on interval training, and they did a nice review on their topic in Exercise and Sports Science Review, published several years ago now, that kind of pulled together a lot of their work and the work of others. And I thought that this was a very nice slide that looked at if you change intensity, and that's using the double-headed arrow there going up or down. If you change intensity, you will notice that VO2 peak goes up, VO2 max goes up, but you also see greater contractile function within the cardiac myocyte, and you'll also see some of the size of the cardiac myocyte be enhanced. So there seems to be this symmetrical relationship between intensity and myocyte function and myocyte size. And they take it a step further. They looked at mitochondrial function as measured here by PGC, and also reuptake of the cardiac myocyte, reuptake of calcium, loading and unloading, so to speak, off of troponin, and that would give it ability to help with not only inotropic effect, but maybe but also the lusotropic effect, its ability of the myocyte to relax. So, and this was an animal model, I agree, but it starts to tie a little bit not only the gross findings of physiology, but also how it might be working mechanistically within the cardiac myocyte itself. Well, I wanted to get a little bit beyond just cardiovascular response and move towards, cardiovascular population and move towards maybe some other patient populations. And the first one to move towards would be comparing. This was a nice paper by Weston where they started to compare some other patient populations. In this case, with some metabolic disorders, hypertension, obesity, and metabolic syndrome. And they've done some work that, they showed what the work of others was in these, in terms of on peak VO2, but showed what others were finding in terms of changes in physiology in a more metabolic population. And then now progressing, and I'll come back to those populations, but now progressing on to patients with chronic obstructive pulmonary disease. Here, Bronsted looked at 17 patients with COPD with really somewhat severe obstructive pulmonary disease, FEV1s of 53%, and put patients in a moderate continuous training group where they trained at 70% of peak heart rate for 47 minutes, versus did HIIT training for 16 minutes, training them up to 90% of heart rate reserve 3 times per week for 10 weeks, and really showed somewhat equivalent, not necessarily better, but somewhat equivalent improvements in peak VO2, work economy, and improvements in stroke volume. So in this model, one could argue that maybe HIIT wasn't quite as effective, but clearly shorter duration, but wasn't quite as effective, was no more effective than MCT, than MCT in improving some of these traditional physiologic markers. And then a review article from a couple of years ago that looked at several papers that were involved with patients with COPD pretty much found a similar concept that HIIT really is not necessarily superior to MCT in patients with COPD. In general, the paper did report less discomfort and less dyspnea associated with HIIT training. And in general, the prescription for HIIT was 3 to 4 times per week across these trials. They used a different interval here, though. You could see 30 seconds work, 30 seconds recovery, or 20 seconds work, 40 seconds recovery, and usually trained at around 80% of peak work capacity. And from that, they found out that HIIT was effective, but not necessarily more effective than MCT. Interesting, a patient population, as we all know now, that's getting marked attention with the role of exercise training in clinical care, and that's patients with cancer who are undergoing chemotherapy. And this was a study by Austin published in 2009, randomized 269 patients to either treatment or usual care, where the intervention was cardiovascular training, but training them with interval training up to 95% of peak heart rate, included resistance training, included massage, and it really a total volume of exercise that I had to go back and double check, you guys, 43 med hours per week, which just is an enormous amount of exercise, concerning for these patients, of which they did for 6 weeks. And they looked at both fatigue and fitness, and fatigue using a traditional fatigue measurement tool. Fitness is measuring both aerobic and skeletal muscle strength, 1RM, and showed modest improvements compared to no change in control, modest improvements in peak VO2, 30% improvements in 1RM, and a reduction in fatigue, almost 7 units, arbitrary units, but 7 units there in both the in the HIIT group as compared to usual care. Another patient population, back to the metabolic patient population. These would be patients with overweight or obesity, women, BMI greater than 25, body fat percent greater than 30%. And in this case, and I'm often struck at how well both overweight and obese patients are able to tolerate exercise, maintain their balance, follow instructions fairly well, able to implement, generally safely, good exercise programs. And in this case, the HIIT was 5 times per week for 12 weeks versus moderate continuous training versus control. The HIIT group did 85% of heart rate reserve, 5 intervals for 3 minutes each, with about 3 minutes of recovery at 50%, compared to 50% of heart rate reserve, which is somewhat low for moderate continuous training. Peak VO2 increased only 8%, but increased and 5% in the moderate continuous group, and body fat, small percent changes, 4% and 2% in the HIIT and moderate continuous training groups, respectively. So we could use, take-home message, you could use in an overweight, over-fat population, good application of HIIT training. In a similar population, TRAP looked at subcutaneous and abdominal fat, comparing high-intensity intermittent or interval training over 15 weeks versus steady-state exercise or control, and it showed in this case slightly greater, but not large, but slightly greater improvements in fat mass, with especially subcutaneous fat in overweight population. So not to beat up all the different special populations too much, but these are some really recent trials, 2013, 2014, involving patients with diabetes, a study involving a population of patients with stroke, just middle-aged to generally healthy people, and again, somewhat typical HIIT models, 30 to 40 minutes, 3 times per week versus MCT, usually training them up to 90-95% of heart rate reserve. And looking at typical variables such as body fat, heart rate response, resting heart rate, peak VO2. In the stroke population, they included a motor assessment scale and 6-minute walk, be a little bit more functional. The study involving middle-aged men looked at actually autonomic function as well. And across the board, in general, HIIT seemed to do better than moderate continuous training for most of the key variables. I will note that in the patients with stroke, which would be the third row under results, you can see that the functional changes that we might look at, were really limited based upon the nature of the person's disability, but something that's really quite functional, such as 6-minute walk, their ability to ambulate, did show an improvement. So it is now being experimented and tested in a variety of different patient populations for master students or doctoral students that are considering now their thesis work or heading towards that. I believe that the application of HIIT or MIT or LIT is wide open in terms of what is the correct dose, what is the frequency, what's the intensity, what's the durations we should be looking at to really optimize, and what are the responses that we should be looking at, for to really optimize training adaptations in our patient populations. So that really heads into, I'm kind of heading into the conclusion of my talk. I still feel there are 4 open-ended questions that we need to start to investigate. I just briefly talked about some ideas that maybe graduate students would want to consider. I think many of these fit into that classifications of in need of future research, or at least in need of future investigation or considerations, and I want to spend a little bit of time on these. One is simply the practicality of integrating HIIT into what we do in, day out. It's not always easy to take one model and have some patients do X while you might have other patients be doing Y. How do we integrate this into standard classes, into standard rehab classes, into standard therapy classes? In patients with different chronic diseases or clinically manifest diseases, is it clinically efficacious? Is it just equal to the efficacy of the the other types of training, if our endpoints might be morbidity and mortality, hospitalizations, remissions, recurrence rates, and we know what exercise from MCT provides with some of these factors is HIIT better or equal. Is it safe? Are we having problems when people are exercising orthopedically or clinically? And then just a couple concluding comments. So to talk about integration, again, I'm going to be very centric to Henry Ford. This is a study that we just finished, just recently published, where we were concerned about, we saw the benefits of HIIT, but how do we integrate patients with HIIT into a typical standard cardiac rehabilitation session that might be 30 minutes long. Patients will exercise on 2 or 3 pieces of equipment for 10 to 15 minutes. And how do we integrate them into the same 30-minute aerobic phase that we have for our other patient population, with letting them kind of do their program and us not having to spend too much time overseeing them? So we randomized patients to either HIIT or MCT that were eligible. If patients had ischemia on an exercise test, then they just got standard care. And so we randomized patients into either the HIIT arm or the moderate continuous arm of the trial. And we had exclusion criteria. As I mentioned, if patients had evidence of ischemia, either anything greater than class 2 angina or ST segment depression greater than 1 millimeter. If they were recent MIs or CABGs, then we waited until they were a little further out. If their ejection fraction was less than 40%, they were excluded. If they had complex arrhythmias or AFib, they were excluded. Or if they had orthopedic limitations that might prevent treadmill walking, we excluded them as well. So I realize others may be testing some of these patients now. Others might include some of these persons, but for our purposes, that's what we looked at. And we randomized 39 patients, 30 of which were men. Age was 53 years on average, to MCT, which was 60 to 80%. And they did 2 sessions of 15 minutes each per bout, 3 times per week for 10 weeks. Or we randomized them to HIIT up to 90% of heart rate reserve with a 4-minute work interval and a 3-minute relief interval. In general, just some results. The MCT group, we eventually had 13 people complete it, and 15 people completed the HIIT arm. They both groups completed about 29 visits of the 30 scheduled, so pretty good attendance there. They both started about the same time, about 25 to 29 days post-hospital discharge. So within 3 or 4 weeks of hospital discharge, they were in cardiac rehabilitation. And the RPE during the MCT portion for those people randomized to MCT was an RPE of on average 12. And in our HIIT patients during the work interval, RPE on average was 15, and the recovery interval was, or relief interval was about a 12. All of our patients received a visual guide that it was only treadmill walking that they put right on the treadmill console, so it actually told them what to do. And you can see the blue these are all of our HIIT patients. The blue is the relief phases or warm up and cool down, and the red are their HIIT intervals, and it told them at what time point, minute, they should go up, and at what time point, minute, they should go down. So you can see this patient went up at 8 minutes to a heart rate of 113, and at 12 minutes they came down to a heart rate between 98 and 105, and at 15 they went back up to get their heart rate up to 113 to 18, and at 19 they went back down to heart rates of 98 to 105, and they could monitor their heart rate either by the treadmill capabilities, or they were also, many of them were also on telemetry, and we could help them with heart rate response if needed. But it was very self-governing, so that we didn't have to spend a lot of time one-to-one with these patients, because there were, if we had 2 or 3 staff people in the class, and there might have been 8 or 12 patients in the class, we couldn't afford ourselves. We had to integrate them into the standard care. We couldn't afford ourselves a lot of one-to-one training time. We measured after the 10 weeks. We measured before peak VO2 and after. Peak VO2, again, very simple measure of exercise capacity. You can see there's about a twofold improvement, which was statistically significant, about a 3.5 ml increase versus about a 1.5 ml increase, about a twofold greater improvement in peak VO2 in the HIIT group versus moderate continuous training. But we also looked at a submaximal parameter, which was a ventilatory-derived anaerobic threshold using the V-slope technology or method. And you can see a marked improvement in submaximal endurance, about 3 ml improvement in the point at which they hit, ventilatory-derived anaerobic threshold in the HIIT group versus a modest change in the moderate continuous training group. So we felt, as you walked away from that, we felt that you could, as we kind of walked away from this study, we felt that you could fairly well adapt integrate right into your training regimen for your patients. So that kind of addressed, at least in our own minds, started to address, can we integrate these people in? But then there's this second question is if you do HIIT, do the patients, yes, they might improve physiologically, but clinically, are you altering endpoints that are clinically meaningful? For patients with cardiovascular disease, are you lowering mortality rates, lowering cardiovascular mortality rates, lowering hospitalization rates? Are you improving quality of life? Other things besides physiologic parameters, things that are clinically meaningful for patients with cancer. It might be, fatigue. But not only are you improving them, but are you improving them to a greater extent than moderate continuous training would have improved these clinical outcomes themselves? We know that in patients with coronary heart disease, that peak VO2 is associated with mortality. And you can see along the y-axis is survival, and these are men and women with coronary heart disease, that men and women with the lowest quartile of peak VO2 don't do well over time with respect to survival. Well, if HIIT improves VO2 more than you would see with moderate continuous training, and we know VO2 is related to survival, could one hypothesize, therefore, then that HIIT would also improve, improve survival? There is no data on this, and I'm purely speculating, but it is a point that we need to investigate. We do know that moderate continuous training, here's the Gospel trial, here's the meta-analysis from Taylor from the UK, I believe, and you can see that moderate continuous training improves clinical markers. Cardiovascular death, MI, stroke improved 30% in the Gospel trial. Total death did not reach statistical significance, but in the Taylor meta-analysis, total mortality was reduced about 20%, and these were with MCT. The question becomes, does HIIT improve it more? We know it improves the physiology, we know it improves VO2, but does it improve these clinical outcomes more? We just don't have data there yet. So another open-ended question that I think we can look at. A third issue we could look at is it safe? Over on the left side of the graph, of this slide, we know, and this is a review article from Art Leon from 2005, that we know that in cardiac rehabilitation, major clinical adverse events happen at about 1 per 50,000 to 1 per 120,000 patient hours. This seems to be, the event rate that most of us have found is pretty typical, 1 per 50,000 per 1 to 120,000 patient hours. A year or so ago, a year and a half ago, the Norwegian group, Rogmo et al., they looked at a retrospective analysis of their data, which again is this Trondheim group, looked at their data where they had 4,486 patients, 58 years, who did both HIIT and moderate continuous training, kind of a mix in their training regimens. About roughly 36% of the time they do HIIT. It was a 3-site retrospective pull of the data, and they had 175,000 patient hours of exercise to analyze in terms of event rates. This next slide shows their event rates. To the left is kind of the standard, 1 per every 50 per 1 to every 120,000. And you can see under the third column there, total training. If you compare moderate and high intensity together, they had an event rate of about 1 per every 58,000 patient risk of an event, 1 per every 58,000 patient hours of exercise. So very typical to what Art Leon reviewed in his paper from 2005. However, if you look at the two right columns, the moderate intensity and high intensity groups, again, high intensity was about 36% of their training time. You can see that the event rate during moderate intensity training was 1 per 129,000 hours, very to the upper end of the event rate reported by Leon. But the high intensity group suffered an event, and they were not frequent, but they suffered an event of about 1 per every 23,000. It happened more frequently that we typically associate with MCT. Take-home message here for me is, I'm very happy that we're starting to look at event rates with HIT. It's very, very important. But this retrospective, not prospective, this retrospective study showed just a glint of maybe the event rates were slightly higher. At least something we have to be cautious of. We have to know, we have to select our patients carefully, make sure patients are stable, and we certainly need more data. We certainly need more data that's looking at patients, looking at event rates in patients with, in this case, cardiovascular disease, to look at safety events. And then you could extrapolate the same thinking to patients with cancer, patients with COPD, obese patients, hypertensive patients. We need event rate data to really talk about, is it comparatively safe as the moderate continuous training type programming. So then just to kind of conclude, there's this whole issue of special programming for special populations. I think a lot of the items that we consider don't change. For the patients with cardiovascular disease, if they have ischemic evidence, they're showing ischemia during exercise, they're showing arrhythmia during exercise, one would argue that until proven otherwise, we would not use HIT in these patient populations and put them into training where they're ischemic. You could hypothesize that you might help their ischemia by giving them some ischemic conditioning, but there have been really no well-done studies that have shown that yet. So I'd be a little bit more speculative. For patients who have obesity, chronic kidney disease, hypertension, we're seeing it in those patient populations as well. And I would say we should consider it. All of your rules or your concerns that you might apply to those patient populations apply to HIT as well. Don't exercise a patient with dialysis on if a patient undergoing dialysis on a day of dialysis, maybe you wait until the day after dialysis. Obese patients, make sure they demonstrate well that they can tolerate moderate continuous training before they handle HIT type training, and you're worried about orthopedics and injuries with them. So monitor that closely. Look at their mode of exercise, maybe more weight bearing early on rather than non-weight bearing than weight bearing early on to make sure they're tolerating it well. So for each of these special populations and others, all the concerns that we would have with moderate continuous training apply here as well. A couple program considerations, at least using, in terms of how we select our patients. In my eyes, I think that all patients should first demonstrate tolerance to maybe moderate continuous training and maybe MIT first before they go on to HIT. So if you're putting them into a cardiovascular rehab program or an endocrinology rehab program or an oncology rehab program, make sure they're first showing that they're demonstrating, HIT or LIT or MIT before you put them on to, a higher intensity training regimen. We don't have a lot of evidence in these other patient populations, but patients with AFib or PACERs, you could raise the question, we need much work, especially the AFib population, and I would even question, whether patients with PACER, patients with aortic stenosis would even be participating in HIT at all. Some of these patients now, because we're very precise in our exercise prescriptive methods, really encouraging for us to get our exercise testing done before we start prescribing MIT and HIT. Yes, you can prescribe RPE. I don't want to make stress test a barrier, but it does allow for a little bit more precision than maybe RPE might allow for, and be progressive. Maybe once you do start MIT or you do start HIT, maybe it's just one time per week that you introduce it, and maybe it's just 2 or 3 work intervals, not a full 3, 4, or 5, before you progress to 2 or 3 times per week, doing all 4 or 5 work intervals. I would encourage that we need much more research here. We vary the modality. What is it with free walking? What is it with bike? What is it with dual action, kind of recumbent bike as well, to see if how does HIT and MIT apply to those patient populations. And again, encourage, if a person just doesn't tolerate HIT well, then we just cut it back to MIT and see how they tolerate that. And then finally, just some personal observations. I've noticed that HIT and MIT really cuts the chatter amongst the patients. It really gets them working. It gives them a planned way to get to the upper end of their training level, rather than just settling into a little less mentally challenging level of work. So we really engage them throughout the whole training bout, rather than just kind of forget and fire and they kind of set at a lower work levels. It forces time at the upper end of the training levels. And I will say that anecdotally, unfortunately, we didn't assess this, but anecdotally, we have a lot of patients tell us they enjoy it more. They felt like they got a better workout. They're a little bit more engaged in the overall training regimen. And I would hope, if adherence is a struggle in our patients, that these types of favorable signals about interest and engagement would help with adherence overall. And then just to summarize, I would say again, as a researcher, as I'm assuming many of you are as well, this is wide open now in this clinical population for us to start to think about well-controlled single-site, but maybe even double-site or triple-site or multi-site trials that are looking at, but not only at the physiology, but at the safety and quality of life and other clinical outcomes as well. So Yuri, I think I'm going to stop there and see if there's questions that your group wants to take along the way relative to the talk.
Excellent. Thank you very much for all that information, Dr. Kane. Definitely very useful. I do have several questions that have come through during the presentation, and we have several minutes here. We could probably get through these very quickly. I'll just read through them as they came in. For phase 2 cardiac rehab, then would the low to medium intensity interval training be recommended? Should the high intensity training, 90% plus, be avoided during this phase of rehab? This is for phase 2 cardiac rehab.
Yeah, a very good question. And I will tell you that we integrated HIT right into our phase 2 cardiac rehabilitation setting. That's what we wanted to test. How well could you integrate HIT amongst all the other confusion and moving parts that normally go on in a phase 2 program? So if I had a class of 8 people or 12 people, 1 or 2 of them might be doing HIT, 1 or 2 of them might be doing MIT, and the rest might be doing MCT. So I would encourage integrating them right in, but teach them, let them self-govern, let them eventually progress where they can manage themselves, and make sure they demonstrate tolerating MCT and maybe MIT before they progress on to HIT.
Excellent. Here's I guess, similar question, but can interval training be started immediately during phase 2 cardiac rehab, or should the patient be able to perform at a certain heart rate reserve or MET level before starting that interval training?
Well, really good questions. I think MET level, you might have to use LIT if they have a very poor functional MET level, but you should be able to do this with any patients with any MET level, whether it's LIT, MIT, or HIT. But as I mentioned, I would say don't start right in with HIT. Let them demonstrate. We had them demonstrate for 2 weeks that they could generate moderate continuous training before we started to introduce MIT, and we went through that very quickly within just a session or so that they could kind of get used to it. And then if they tolerated it, they would move them quickly up to MIT. The patients will tell before we progress them up to HIT. You can tell if the patient's struggling at all, if they're, they'll back themselves off. But in general, they adapt to this fairly quickly over time. Not everybody, but fairly quickly over time.
Excellent. Here's, I guess, one of the a popular question is, how do you adjust for patients with beta blockers?
No difference. So the same way that we prescribe heart rate reserve on beta blockers, we use the same heart rate reserve formula, whether all of our patients, I think almost all of our patients were on beta blockers. We use the heart rate reserve formula, peak minus rest, and we did do an exercise test on everybody, peak minus rest, and we would prescribe then at 60 to 70% or 60 to 80% or up to 85 or 90%. We just used the different percentages based upon what method of training we were using. But beta blockers did not interfere with how we went about things.
Excellent. See another question here. Is it necessary to monitor heart rate continuously during HIT, as you mentioned in your hospital? So do you monitor with telemetry? What about without heart rate monitors? How will they do it?
Well, I think somewhere along the way, we really try to get patients off monitors, whereas most patients eventually were off monitors. They did have at their treadmill the hand grips where they could get a quick look of their heart rate to make sure that, assuming that those quick look systems were working well, to get a quick look of where they could kind of get some self-feedback on what heart rates they were training at. If we were ever in doubt, we would put people back on a monitor and we would use the monitor, the telemonitor. But you can do this without, maybe introduce it with tele, but you can progress people off of tele without a problem. So I would encourage, just for precision, that patients learn how to guide their paces, so to speak, associate an RPE with a heart rate. So if they eventually have to get off of heart rate monitoring and go by RP only, they kind of have a feel for how heart rate relates to a certain RPE. But you could go RPE only. Several sites are doing that. We tended to focus a little bit more on a heart rate-based approach and got them off of telemetry, let them use the heart rate devices that came with the machines where they could do the hand grip and see what their heart rates were, and do it that way. But the patients themselves, eventually you could see they were going by how they felt, which was kind of RPE guided, and that worked well too.
Great. One more question here. Based upon your experience and knowledge of the literature, what is the most common work interval duration utilized?
Wow, really good question. I would say the 4-3, the 4 minutes of work and the 3 minutes of relief. And that's not to say that, I know Dr. Meyer in Europe has used a much shorter, 30 seconds, 60 seconds. I think even some places in the U.S. use a 30-second, 20 seconds. So it's not to say others aren't doing it, not saying good results. But in general, I was just more comfortable with a little bit longer, little less to have to deal with changes on a rapid, patient have to follow rapid changes, quickly, so to speak. I was just a little bit more comfortable with spreading it out and using the 4-3 model, but I think that tends to be a little bit more common in the literature.
Okay, let's see. If a patient has a ST without a beta blocker, would you then still prescribe a target heart rate for a patient that regularly takes a beta blocker?
So, Yuri, start that one again, because I'm not sure I've got it 100%.
Yeah, if a patient has a ST without a beta blocker, I would assume that this is all they wrote, so I would imagine it says ST segment depression.
Okay.
Without a beta blocker, would you still prescribe a target heart rate for a patient that regularly takes a beta blocker?
So I apologize if I'm not interpreting this correctly, but if an exercise test is done on a patient and they demonstrate ST segment depression, and then their physician puts them on a beta blocker, I would ask that the test, for HIT purposes and for training purposes, I would ask the test be redone on the beta blocker to find out if they still show evidence of ischemia. If they show evidence of ischemia that's greater than a millimeter right now, I probably would avoid HIT and then just keep them at 10 beats below where they show evidence of ischemia. If they don't show evidence of ischemia on the beta blocker, or it's less than a millimeter, let's say a half or so, then I would potentially work them up to MIT. I would prescribe it based upon normal heart rate reserve methods. Work them up. Start with MCT. They demonstrate that well for a week or two. Maybe try some MIT because that's within the same training range as MCT. And then if they tolerate that well, keep a close eye on things, but then start to introduce HIT as well.
Great. We'll have a couple more questions here. What would you do? Would you do a high intensity training without a symptom limited test prior to starting? A symptom.
Yep. Yeah. I mean, these are just real world questions, you guys. Good stuff. And we do have the luxury at Henry Ford that we are able to get exercise tests on most all of our patients that we think we're going to put into any kind of serious training, MIT or HIT, so to speak. But I do understand that in the community setting, that's not always the case, and you don't have that luxury. So I would say, since we know guidelines do exist for us to prescribe exercise based on RPE, that we use the RPE method. But I would say for right now, keep RPE in the 11 to, let's say, 14 or 15 range, with the 11 to 12 being in the relief area, and the 13, 14, 15, maybe 14, 15 range being the upper end of the work interval. We just don't have an awful lot of data on maybe touch upon 16. I guess our data had people training at the 16 end as well. So one could make the argument that we were able to capture RPEs up to about 16. I would be very cautious just because we don't have the data of training patients to an RPE of 17.
And I guess the following question goes right along with that. How would you start to prescribe that high intensity training if you didn't have that stress test information?
Yeah, so no different. I mean, I think than we normally do. We'd set patients at an RP of 12 to 14 for in moderate continuous training, 12 to 14 for 30 minutes. They might start out, go use the bike for 10 minutes, or go use the treadmill for 10 minutes, or go do your walking for 10 minutes, and they would rotate that around until they get their 30 minutes in, and we slowly progress them up to training 30 minutes, at an RPE of 12 to 14. So really no different there. But for those patients that are functionally in need of more work because of occupation or interest, or just interest, or we think that they're not training as hard as they could within a range of 60 to 80%, we might introduce a MIT where they start to train at the we say, okay, we want to do 4 minutes at an RP of 12 to 13, and we want to of 13 to 15 or 13 to 14, and then back down to 12 to 13. So you're kind of mitting their RPE up and down within this range of, let's say, 11 to 14 or so, which is typically the range that we keep most of our continuous patients at. And then if they tolerate that, we go on to the next step, and we say, okay, we'd like to make 1 or 2 of your intervals. Don't go up to an RP of just 14, but push it up to maybe a 15 or a 16, hard work, and do that for 4 minutes, and then back down to an RP of, for 3 minutes, back down to an RP of, let's say, 12 or 13 or so. And we start to introduce more and more of those work bouts, maybe once a bout or twice a bout, and then once they're handling that, maybe once or twice a week. And then when they're comfortable, they could be doing that maybe even 2 or 3 times per week. I know that's convoluted, Yuri, and it's hard to explain, but
Sure.
hopefully the people get the idea.
Definitely. And Dr. Kane, one more question, and I think this one kind of is going to throw a little bit of a curveball because we really haven't talked about it. But what are your thoughts on taking a higher intensity approach to resistance training in some patient populations?
Wow. Okay, that's a curveball. And I'd have to say I don't live in that wheelhouse enough to answer that. Could you do it? Probably so, but I would be concerned a little bit with training people at 90% 1RM, 95% 1RM versus, traditionally 85% 1RM versus traditionally, what do we usually go 70%? I just don't know enough. And to the best of my knowledge, there is no data on that. So I'm going to plead soft on this one and not get into the water, Yuri.
Okay, and if you don't mind, I have a really good question, and I think everyone will be interested. It's what's the reason for excluding patients with AFib from doing HIT?
Okay, so I would say not a good, since we hadn't dealt with it before, we just decided to exclude them because we were going on a heart rate based approach.
Got it.
And because you just you can't monitor heart rate, right, in patients with AFib.
Correct.
But I would say that's a really, really prime suspect group that would be right for a study involving just AFib patients. So if I could randomize, 15 AFib patients or 20 AFib patients to moderate versus, MIT to HIT, I think that would be right, prescribed by RPE only. So if they didn't have an ICD, if their AFib, let's say, wasn't due to heart failure with systolic dysfunction, if they didn't have an ICD and you didn't have to worry about where their heart rate went, and you were worried too much about where their heart rate went, and you were worried more about just training based upon RPE, I think that would be a really good group to study and take them out of an exclusionary category. But Yuri, we have no data on that, and I think it's ripe for data.
Excellent. Well, thank you very much, everyone, for attending. Great thank you to Dr. Steve Katayan for all the wonderful information. Hopefully this is useful for everyone out there to take to their patients and start incorporating some of the information that was provided to us. Again, thank you, everyone, for attending today's webinar, and we'll see you in the next webinar, which will be about a month or so from now. Thank you very much. Have a great day.
Thanks, Yuri.